So we're just going to start. So good evening, everyone. And first of all, Happy New Year, as per Hindu calendar. And so this is the 20th online teaching class under the banner of Up-Aroi. And under the breast series, this is the third class, which is the landmark trials in the carcinoma breast radiotherapy. For this, I would like to invite Dr. Subohi Jafar. She's a consultant, Crest Galaxy Cancer Institute, Muradabad. Dr. Subohi, it is over to you.
Thank you, ma'am. First of all, I would like to thank Dr. Shaleen sir, Dr. Surbhi ma'am, Dr. Ashutosh sir and Rashi Agrawal ma'am for giving me the opportunity to moderate today's important lecture, that is landmark trials in carcinoma breast radiotherapy. And we are very fortunate to have Dr. Tabassum for today's lecture, and she is professor in the Department of Radiation Oncology at TMH Mumbai. And she has done extensive research in breast radiotherapy, and she is also conducting 2 randomized trials at TMH. One is about the hypofractionated radiotherapy in reconstructed breast, and other one is NNBC trial that is evaluating the role of PMRT in node negative patients. So without wasting any further time, I would like to invite Tabassum ma'am for today's session.
Yeah. Thank you very much, Dr. Suboi, for a kind introduction. So even I would not like to waste time, and I would start with the presentation. A very good evening to all dear students. So in this seminar, I would try my best to give you a summary of all the landmark trials in breast that are important in breast cancer radiotherapy. So I intend to address the trials related to adjuvant radiotherapy, both in the BCS as well as post-mastectomy setting, trials on regional nodal irradiation, hypofractionation trials, and APBI. So if I'm unable to finish everything in 1 hour, maybe we can extend the time little further. We know that radiotherapy in breast cancer has evolved tremendously. There are changing paradigms, and no longer radical mastectomy is the standard of care. We are now following offering breast conservation therapy for most of the patients that are eligible. And similar to surgical standards, radiotherapy is also evolving, and we are now slowly moving from whole breast radiotherapy towards accelerated partial breast radiotherapy. And in very select cases, also trials are ongoing for omission of radiotherapy. So starting off with the adjuvant radiotherapy trials in the BCS setting. First of all, it is important to know about the trials that have shown the non-inferiority of breast conservation approach with the mastectomy approach. So in the current day, we advise mastectomy only in patients that are not eligible either in view of locally advanced tumor or poor response to neoadjuvant chemotherapy. And breast conservation surgery, which involves wide excision of the lump with negative margins, appropriate auxiliary surgery, and radiotherapy to the whole breast with a boost incorporated in eligible patients. So several trials and meta-analysis have compared the efficacy, and they have convincingly shown that BCS approach results in comparable local control, overall survival, and gives the dual advantage of better cosmetic outcome and better body image. So this is the slide that is summarizing the trials that have compared mastectomy with BCS plus radiotherapy. And as you can see, you would note that a little higher incidence of local recurrence was seen in few of the trials, and this was essentially related to inclusion of a small proportion of patients with positive margins. Hence, the standards for breast conservation surgery have also to be followed, and you cannot accept a patient with positive margins. However, it is important to note that survival was not different in both the treatments across all the trials. Hence, in mid-80s, breast conservation therapy has been standardized worldwide, and that forms the essential surgical management for early breast cancer. So this is the summary of trials that are comparing in the BCS setting, that are comparing BCS alone with BCS plus radiotherapy. So the inclusion criteria of each of these trials have been variable, and the tumor sizes restricting ranging from 1 centimeter to 4 centimeter, and essentially the randomization was between radiotherapy versus no radiotherapy. It is also important to note that the surgery was also different. People were wanting to uh, evaluate whether extensive surgery, means not mastectomy but a quadrantectomy or a sector resection, would compensate the need of radiotherapy. And hence you can see that in few of the trials, the surgery was more than lumpectomy but not mastectomy. You can one can note that the IBTR rate, that is ipsilateral breast tumor recurrence rate, was significantly less in patients of radiotherapy arm. And however, in the earlier trials, the impact on overall survival was not very evident. Of course, there was impact on breast cancer specific survival, though numerically you can see that the overall survival also has shown improvement. And very important to note that all these trials have now given long-term mature data of around of 10 to 15 years. Hence, there is a level 1 evidence of offering adjuvant radiotherapy after breast conservation surgery. So these were the trials in which the population was unselected. All patients were eligible irrespective of the patient factors or demographic factors or pathological factors. Hence, all these trials have been evaluated, have been meta-analyzed in the EBC-TCT meta-analysis, which is evaluating different treatments across breast cancer, be it surgical treatment, radiotherapy treatment, systemic therapy, or hormonal therapy treatment. So the rounds of EBCTC meta-analysis happen every 5 years. And in 2011, this meta-analysis convincingly showed that there is an absolute reduction in the any first recurrence to the tune of 15%, which translates into a gain of 3.3% improvement in the survival for node negative patients, and for node positive patients, this benefit is to the tune of 21% reduction in any first recurrence and 8% reduction in the breast cancer mortality. Hence, to conclude, it is important that radiotherapy to the conserved breast halves the rate at which the disease recurs and reduces the breast cancer death rate by about a 6. And radiotherapy was given in conventional fractionation over 5 to 6 weeks in all these randomized trials. Hence, all patients undergoing breast conservation surgery should receive adjuvant radiotherapy. The next important component of adjuvant radiotherapy is delivering a tumor bed boost. So this was the Eotc large trial that was performed in 4,000 women, in which the additional boost was given in sequential manner. 16 gray in 8 fractions was given after 50 gray. And as you can see the plots for the cumulative incidence of recurrence, you can see that the maximum benefit is in young patients, and patients less than 40 derive the maximum benefit. And the reduction in recurrence is almost half, from 13.5% to 24%. And the benefit reduces as the age of the patient increases. And above 60 years, the benefit is quite less. So the 20-year follow-up data of this trial was published in 2015. And as you can see, the impact of the boost was manifested in terms of reduction in the local recurrence. However, there wasn't any difference in the 10-year survival, overall survival. At the same time, there is definitely 2 to 3 times increase in the risk of severe fibrosis, which is localized to the tumor bed. And the incidence at 20 years is 4.4 versus 1.6, which is numerically very less. And there is slight detriment in the cosmetic outcome as well. And hence, the boost radiotherapy has to be tailored depending upon the risk of recurrence. It was also noticed that 47% of the recurrences were still, despite giving boost, were still localized to the primary tumor bed. 10% was in the scar, 29% was in regions outside the original tumor area, and in 13% of cases, the recurrence was diffuse. Very important endpoint of breast conservation is the ability of women to save the breast. So there was 41% reduction in the salvage mastectomy rate, and the predictors of recurrence that were very important were grade, that is high grade, and presence of ductal carcinoma in situ impacted the timing as well as the development of IBTR. Hence, it is essential to maintain basic standards for breast conservation therapy, which starts from patient selection, and the patient has to be desirous, and the procedure should also be feasible. Optimal cosmetic outcome should be the goal of breast conservation, and there have been changes in the definition of negative margins, and we have moved away from 5 millimeter to 2 millimeter to now no ink on the tumor. And as I have already mentioned in the first slide, that summarized the higher recurrence rates in due to accepting for patients with positive margin, it is very important to achieve negative margins. Positive margins confer twofold increased risk of IBTR, and which it cannot be mitigated by giving radiotherapy or systemic therapy. And it is also important to follow a protocol for clipping the tumor bed either at the base or at the walls. And a clinical diagram would definitely help understand the tumor location prior to therapy, especially in cases of oncoplasty. Now, coming to the trials where a patient population was selected. In all these trials, this CALGB trial, the Toronto trial, the Prime2 trial, all these trials, the patient population was selected in such a way that all the risk factors were very favorable. So as you can see, all the patients were node negative, patients were hormone receptor positive, and except for the Toronto trial, or rest of the trials restricted the tumor size to 2 or 3 centimeter, and all mandated negative margins, and other factors, high-grade factors like grade 3 or LVI were allowed in few of the trials, but essentially they were all restrictive. And the randomization was between giving observation of, giving hormone therapy alone versus hormone therapy plus radiotherapy. So as you can see, definitely in the radiotherapy arm, the local recurrence rates are definitely less, but there isn't much impact on the overall survival. And this data is also pretty pretty good median follow-up, more than 5 years, and the follow-up ranging from 5 to 10 years. It is also important to derive valid conclusions, because these results should be generalizable in our non-trial patient population, and the factors that can be considered while extrapolating these results would be the expected life expectancy, competing causes of death that can dictate survival in elderly patients, and what is very striking from these trials is that all these trial population was having extremely low risk patients, because very few recurrences were noted in all the trials. So that also gives controversial views in the form of whether these patients need adjuvant treatment at all, and if they need, should they receive hormone therapy alone, or should they be offered radiotherapy. And hence, we need to discuss the burden and side effect of both the treatments, and the choice between short course radiotherapy versus prolonged hormonal therapy is to be discussed with the patient. I'm not very confident whether our patients would be able to understand all these nuances, but yes, these are this is what the evidence supports, and in appropriate patient who is well educated and can take decision for herself, these nuances can be discussed. And the survival benefit would definitely, in such a low risk population, would be definitely difficult to demonstrate, because the baseline risk itself is low. And hence, the other reason for lack of showing survival benefit would be because local recurrences are easily salvageable, and wider margins can further lower the risk of local recurrence. As QL is a very important endpoint, new measures should be incorporated, and trials in omission of radiotherapy should delve more deep into the quality of life endpoints, patient-reported outcome, and not report on overall survival or the as the primary endpoint. Hence, there have been various studies that have been ongoing that are selecting patients or that are trying to identify low-risk patients based on the biomarker-based patient selection. And these are the various studies. Few studies are selecting based on the oncotype DX, Prosigna, various genetic molecular markers are being used, and however, the Lumina and the Prime Time, which are based on the IHC4 score and the addition of clinical factors, would be more practical. The results of these trials will be more applicable to our population, because these are based only on IHCs and clinical factors rather than molecular signatures, which most of our patients may not afford. So these are the ongoing studies, and we await the results of these studies to be able to offer omission of radiotherapy in appropriately selected patients. Now coming to the studies on adjuvant radiotherapy post mastectomy. So very important are the two most important trials are the Danish 82B and the 82C trials. And 82B trial was done in 1,700 women in premenopausal women of stage 2 and 3. And both node negative as well as node positive patients were included. And here, as you can see, the chemotherapy is quite suboptimal. Only 9 cycles of CMF were given, and radiotherapy was added in the other arm. Whereas in the 82C trial, which was in postmenopausal women with similar inclusion criteria, but as this was it included 10 to 15% of women with locally advanced tumors, and the randomization was between TAM alone versus TAM, and that was also given only for 1 year, versus tamoxifen plus radiotherapy. And the median number of axillary lymph nodes that were removed were less, only 7, and all patients received radiotherapy to the chest wall as well as the internal mammary chain using electrons. And SCF and axilla was treated with anterior photons. And radiotherapy was used to a dose of 50 gray, 25 fractions, and small proportion of women also received radiation with ortho voltage. So these are the results of the 82B trial. As you can see, there was remarkable reduction in the local recurrence rate, which manifested as increase in the 10-year DFS as well as overall survival. And you kindly note the absolute benefit of 11% in the overall survival and 14% in the disease-free survival. Similar was the result of the 82C trial. And here also the reduction in local failure to the tune of 27%, and improvement in the DFS by 12% and overall survival by 9% was seen. And it is very important to note in both the trials that in the arm without radiotherapy, the incidence of recurrence is very, very high. It is 35% and 32%, which is not an acceptable, which suggests that there were other treatment-related factors that were suboptimal, which has resulted in such high local recurrence rate. And hence, these results cannot be extrapolated in modern-day treatment era. Modern era, because all the forms of treatment, be it surgery, systemic therapy, and radiotherapy, is optimal. these trials were included in the Ebcdc meta-analysis of 2005, and in this meta-analysis also the benefit was proven for 1 to 3 lymph nodes, and uh, uh, both in terms of reduction in the recurrence as well as improvement in the breast cancer mortality and overall mortality. But this never became a standard of care. And the reasons I have already mentioned, these included inadequacy of the surgery, especially the axillary surgery, as well as hormone therapy duration, non-anthracycline-based chemotherapy, which was also given only in nine cycles, and high axillary failure rates, lack of hormone receptor status that was studied. So there were inadequacies in the patient baseline characteristics as well as the treatment offered. Hence, it did not ever become a standard of care. However, slowly over the years, the uptake of PMRT for this subset of patients has been increasing, and the more in favor of giving RT for 2 or 3 lymph nodes. So this meta-analysis was published in 2014 because they excluded, they wanted to report on patients that had received adequate treatment. Hence, they only did individual patient-based meta-analysis in patients who had received adequate surgery in the form of either a axillary dissection or a sampling, and these women had also received systemic therapy. So as you can see, in this selected population where all the treatment factors were known, this comprised of 1,300 patients with 1 to 3 lymph node and around 1,800 patients of 4 and more nodes positive population. So in both the subgroups of 1 to 3 as well as more than 4 or more nodes, the benefit was seen with respect to the reduction in the locoregional recurrence rate, any recurrence rate, as well as improvement in the breast cancer mortality. And as you can see, the benefit of breast cancer mortality was to the tune of 8% in 1 to 3 lymph node and 9.3% in the 4 or more node positive. Hence, reduction to the tune in locoregional recurrence to the tune of 15 to 18% was noted, and breast cancer mortality up to 8 to 10% reduction was noted. So PMRT has become now the standard of care for all node positive women, irrespective of the number of lymph nodes positive. And following this meta-analysis in 2017, the ASCO guidelines also recommended that radiotherapy or post-mastectomy radiotherapy should be offered to 1 to 3 lymph node positive patient population. The ongoing trials that are addressing other questions like high risk node negative patients, as well as there was ongoing controversy in N1. So the Supremo trial is including both the N1 patients, that is 1 to 3 lymph nodes, as well as T2 tumors with high risk node negative patient population. And the approval is completed, but we await the results. And the TMH trial is addressing this question only in node negative patients that are high risk, both T1, T2, and the high risk factors included in them are the LVI, ER status, HER2 status, and grade, as well as age of the patient. So this is an ongoing trial. Now coming to the important trials of regional nodal irradiation. This is the slide that is summarizing important trials, randomized trials for Ironman irradiation. So the only trial that was addressing the additional benefit of Ironman was the French trial, and in this the randomization was between offering Ironman RT versus no Ironman RT. However, in the other two trials, that is the Eotc and the Ma20 trial, a comprehensive regional nodal irradiation was given. And the Danish trial was not a randomized trial; it was just the Danish guidelines recommended that right-sided women should receive IMNRT and left-sided women should not receive IMNRT. So this was a comparison between right side and left side that were offered. Right-sided were offered internal mammary nodal irradiation. And you can see that the receipt of adjuvant systemic therapy is also variable across the trials, and the dose of radiation and the method of delivering radiotherapy is also different across the trials. However, we do have mature results from all these trials. Coming to the first trial of internal mammary nodal irradiation, which was the French trial, the primary endpoint was 10-year overall survival, and they were very, very optimistic, and they wanted to show a 10% difference in the overall survival with IMN irradiation alone. And the pre-specified subgroup analysis was for tumor location, axillary nodal status, and adjuvant therapy. And in here, they irradiated the upper 5 spaces, and the IMNRT was treated with photon-electron combination and a 4 to 6 MB or a cobalt machine with the IMN was given at a 3 centimeter depth and covering the upper 5 intercostal spaces. And the prescription was 45 grain, 18 fractions. And one of the trials also used extreme hypofractionation, that is 26 grain, 6 fraction. So this trial did not show any difference in the late effects, and however, the cardiac evaluation was not done systematically, and the criticism was that it was too optimistic to show improvement of 10%, and the control arm had much better survival than assumed. Hence, the trial was underpowered, and though they did not show any difference in the late effects, but because they had included upper 5 spaces, so there is a distinct possibility of cardiac exposure. So this was a negative trial. The next trial is the Eotc trial, which was done in 4,000 women, a very big trial. And here again, the endpoint was 10-year overall survival, and they looked at 4% difference, which was practical to achieve, and they wanted to show improvement from 75 to 79%. And here the prescription was 50 gray in 25 fractions. Again, photon-electron combination was used, and upper 3 to 5 spaces were irradiated depending upon the tumor location. Those tumors in the lower quadrant were irradiated with 5 spaces, and rest of the tumors, upper 3 spaces, were irradiated. So this, you can see these graphs side by side. Those on the left-hand side are the trials that were published in 2015, and those on the right are in 2020, the recent update of the trial. And you can see that there isn't any difference in the overall survival, no benefit in statistical benefit in the overall survival, and the 2015 publication did show some significant benefit with respect to distant metastasis-free survival. However, the same thing, this was also the significance was also lost at the mature follow-up. So it is a negative trial with respect to the primary endpoint, and again they did not evaluate a proper systematically cardiac evaluation was not done, and here they did not split the target volume with respect to IMN contribution of IMN, and it was a comprehensive nodal irradiation. Coming to the Ma20 trial, this was again a large trial in 1,800 patients, and again the endpoint was overall survival, showing 5% difference, and the prescription was similar to the Eotc, and they irradiated the upper 3 spaces only. And this trial also did not show improvement in the overall survival. However, there was some difference in the isolated locoregional disease-free survival and the disease-free survival. But the primary endpoint, which was overall survival, the trial was negative with respect to the primary endpoint. And the toxicities in the 2 arms, obviously the RNI arm had higher dermatitis, pneumonitis, and higher incidence of late toxicity to the skin and the subcutaneous tissue, which and also lymphedema. The rate was 4% versus 7%. Coming to the last trial of Ironman study of related to internal mammary irradiation. So as I said, this was a prospective nationwide population-based cohort study, and this study was in the treatment principles of irradiating on the right side Ironman and not irradiating on the left side was there until 2007. And this was essentially the pre-taxane era, and here anthracycline-based chemotherapy or CMF and hormone therapy for 5 years was given, and the dose of radiation was 48 gray in 24 fractions, and the upper 4 spaces were treated, and again the primary endpoint was overall survival, and at the median follow-up of 9 years, the study was reported. So these are the two graphs that show that how Ironman RT, after the introduction of taxanes, how the use of Ironman RT even for the right-sided had reduced, and as this also corresponded with the increase in the use of the hypofractionated radiotherapy. So this is essentially a data from an older cohort, though the variabilities with respect to systemic therapy, dose of radiation and all is not there. But this is also an essentially older data. Patients treated in older times. So this study evoked a lot of reactions in the breast oncologist, and because this showed an improvement in the overall survival, significant improvement in the overall survival, as well as breast cancer specific mortality and distant recurrence also. And the most important subgroups that benefited were the medial centrally located tumors that with 1 to 3 lymph nodes, and if 4 and more nodes were reported, then lateral tumors also benefited from Ironman irradiation. So there were a lot of controversies pertaining to internal nodal irradiation after the publication of the Danish study, because none of the other randomized trials had shown any overall survival benefit, but this study did evoke reactions in the and the issue remained unresolved. But the matured 20-year data of the Eotc failed to show any benefits. So now the popularity of internal mammary irradiation is going down, and even at that time, earlier time, the guidelines were also promoting new indications for internal mammary irradiation, even in early breast cancers. So in order to resolve all these controversies, this was the Ebcdc meta-analysis for regional nodal irradiation that was published in SABCS 2018, but there isn't any publication till date, despite being 2 or 3 years after the presentation in the conference. And here they evaluated 14 trials that were addressing different levels, target areas of lymph nodal areas, regional nodes. So they splitted they showed the benefit after splitting the trials into older trials and the newer trials. And as you can see, the older trials did not show any benefit. In fact, there was there was a detriment with respect to overall survival, but the newer trials did show a benefit with respect to any first recurrence, and same was seen with respect to the breast cancer mortality, and there was a loss by 0.5% in the older trials, but there was a gain by 2.8% in the newer trials. A similar trend was seen in the overall mortality with respect to the benefit and loss in the older trials. And the subgroup, the analysis, the forest plot showed that the benefit was maximum in 4 and more nodes positive, and some benefit also in 1 to 3 lymph nodes and those tumors that are medial and centrally located. Hence, they concluded that the older trials, the breast cancer mortality had no effect, and in fact, the overall mortality was significantly increased. But the newer trials did show a significant reduction in the breast cancer mortality and overall mortality, and the absolute mortality reduction was greatest in patients having more than 4 lymph nodes positive. The other area of regional nodal irradiation, which we talk more often now in the current era, is the role of regional nodal irradiation following sentinel lymph node procedures, because these are the recent trials and recent evidence. So the evolution of axillary treatment has been tremendous, because now axillary lymph node dissection is not mandatory, because SNB has replaced axillary lymph node dissection for staging of clinically node negative women who remain negative on sentinel lymph node, as well as data from the IBCSG trial. It also shows that SNB alone is safe for patients having micrometastasis. However, the publications of the Z11, Otosor, and the Amaros trial have been debated with respect to their clinical application, because these trials included micro as well as macro metastasis. And I would be addressing these in my subsequent slides. And recently, there is also mature early results of trials that are addressing the question only in the macrometastatic setting. And the Synodal trial, the Sinomac and the POSNOC trials are addressing the setting of SNB with macrometastasis. And on the other extreme, there are also trials that are testing the omission of SNB. That means no axillary surgery at all in very, very favorable or low risk population. So the trials addressing the micrometastatic disease, there are 5 trials: the IBCSG trial, the ATRM trial, and the Z11 trial. Whereas those testing axillary lymph node dissection with radiotherapy are 2, Amaros and the Otosor trials. So a mix of micro plus macrometastasis was there in the Z11 and the trials addressing radiotherapy as one treatment modality. So this is the slide that is summarizing the results of the Amaros trial. So in this trial, the randomization was between SNB alone and versus regional comprehensive regional nodal irradiation. So as you can see, level 1 and 2 were addressed in the SNB, and in regional nodal irradiation, level 1, 2, 3, as well as the medial supraclav was irradiated to a dose of 15-25. It is important to note the very favorable characteristic of this trial. 82% were patients who had undergone BCS. 82% women had T1 tumors, 80% had hormone receptive tumors, and 72% had grade 1 to grade 2, and 60% of this population had macrometastasis. The summary of the trial is that the toxicity, when you talk about the acute toxicity, obviously the acute toxicity was higher in the SNB arm. In the axillary lymph node dissection arm, it was 23% versus 9%, and the late toxicity showed a remarkable difference in the incidence of late toxicity favoring radiotherapy. The lymphedema rate, whether it was measured by clinical observation or by measurement, was significantly less in the almost half in the radiotherapy arm. And the incidence of paresthesias were much lower in the radiation arm. So it is important that in appropriately selected patients, we do offer radiotherapy as an option for these patients for treatment of axilla. However, there was no difference in the overall survival, and lymphedema is a very, very important endpoint, because it gives a constant reminder of cancer to the patient, and as the treatment is lengthy and costly, patient compliance to the management of lymphedema is also poor. So this is the updated result that were published, and here they have shown that the difference in the shoulder function that was measured with respect to the range of movement, either anti or retroversion and abduction or adduction, and it was seen that there was no significant difference in all the 4 excursions. And though the quality of life does drop a bit in the radiotherapy arm at around 1 year, but at it picks up slowly, and at 2 years and 5 years, the difference in the quality of life is also not very evident. The other trial also addressed the compared axillary lymph node dissection with regional nodal irradiation, and at a mean follow-up of 97 months, this trial also published similar results and significantly less toxicity in the patients receiving RNI, and there was no difference in quality of life. And the very common finding that there was no difference in the quality of life because the radiation, as I shown here, is not a conformal radiation, and a shoulder could have been spared, and this would have also improved the could be contributory to the no difference in the quality of life in the patients receiving radiotherapy. So this is the summary of the trials that are addressing the question of further treatment after sentinel lymph node biopsy. So as you can see, the percentage of positive lymph nodes after SNB on further axillary dissection is to the tune of 27% in the Z11, whereas the IBCSG and the Adjuvant trial, they had very favorable trial population, and hence the additional lymph nodes that were positive were only 13%, and more than 1/3 patients were positive in the other 3 trials, and this has reflected in the low recurrence rates in the axilla, and at the same time not showing any difference in the survival outcome. So with respect to SNB further treatment, I would like to summarize by saying that extremely low risk population that were treated in IBCSG, there is no need of any further treatment. Those with intermediate risk, for example, patients even without LV or extranodal extension and limited nodal involvement in the form of 1 or 2 lymph nodes and clinically node negative, these are the patients who may be offered axillary radiotherapy, but the rest of the other patients who fall into the high risk category, they can be, they should undergo axillary lymph node dissection. Now, coming to the trials evidence for hypofractionation. This is a slide that is summarizing the timelines for the UK trials, which is given in the diagram above, and the other non-UK trials below. So multiple trials have been carried out in the world, and different with different settings and different schedules, and hence this makes the evidence for hypofractionated radiotherapy for breast cancer very, very robust. The summary, this is the slide showing the summary of the UK trials. As you can see, the conventional radiotherapy comprises of 50 gray given over 5 weeks. The START-A trial did not reduce the overall duration of the radiotherapy. Same was true for the FAST trial, but the START trial offered 5 fractions in fortnight. And in FAST trial, 1 fraction was given in 1 week. The other 2 trials, that is the START-B and the Fast Forward trials, they also reduced the overall treatment time from 5 weeks to 3 weeks. And the Fast Forward trial further reduced the overall treatment time from 3 weeks to 1 week. And we have, except for the Fast Forward trial, we have mature 10-year data from all the other three trials, and they all convincingly show non-inferiority of the test arms. Coming to the Rmh trial and the START-A that had no reduction in the overall treatment time, you can see that these were large trials, 1,400 patients in Rmh trial and 2,200 patients in the START-A trial. And the proportion of patients that were node negative was was higher in the Start A trial to the tune of 70%, and grade 3 tumors were only 28%. Majority of the patients had undergone lumpectomy, and patients receiving boost were very few. The EQT2 of the regimens, both the trials were 3-arm trials, and 39 gray in 13 fraction was compared with 42.9 in 13 fractions in the Rmh trial, whereas the 39 gray in 13 was the same in the Start A, but here there was a reduction in the second test arm, that was 41.6 gray in 13 fractions. And the incidence of normal tissue toxicity was also comparable in the test arm. So I would be showing the individual trials in detail now. In this trial, in the Rmh trial, the fraction sizes selected corresponded to the extreme limits of the fraction sizes, that is alpha beta of 1.8 gray and 6 gray. Because while doing the trial, they from the radiobiological experiments, they had got a range of alpha beta ratios. So that's why the 2 arms that were selected in the Rmh trial represented the extreme of this alpha beta, and that corresponded to these dose fractionation schedules. And here they were treated 5 times per fortnight, and the primary endpoint was the late change in the breast appearance compared to the baseline scores, and these were analyzed using the annual photographs of the patients. And there were several endpoints, secondary endpoints, that included breast induration as well as breast tumor recurrence. So as you can see, the probability of any marked change was 5.6% versus 10.1% versus 3.4%. That means the arm with 42.9 gray was having a higher incidence of late effects, and same thing was seen in the induration also, 28.6% versus 41% versus 20%. And with from this they derived the alpha beta of 3.6 gray for marked change in the appearance, and 3.1 gray for the induration. And of course, there was not much difference in the pattern of recurrence in the 3 trials. So the alpha beta for the recurrence that was derived was 4.1 gray. And hence this derivation, they derived 41.6 gray into 13 fractions, was thus derived from indirectly by these results of toxicity and recurrence. So this was chosen in the Start A trial. This fractionation formed the second test arm for the Start A trial. So this trial, the primary endpoint was locoregional control, and the secondary endpoints were late effects and the quality of life. So there wasn't any significant difference in the locoregional relapse rate, which was the primary endpoint, and both the 5-year and the 10-year data supports the safety of hypofractionation in adjuvant breast radiotherapy. So, when various late effects were studied in both 41.6 gray arm versus 50 gray and 39 gray versus 50 gray, it was noticed that the 39 gray arm was little milder than the 50 gray arm, and whereas 41.6 gray arm was equivalent to 50 gray, and in all the endpoints, the toxicity, with respect to toxicity, it was non-inferior. So a lower total dose in a smaller number of fractions could offer similar rates of local control and normal tissue damage. So this formed the international, changed the practice worldwide and formed the new standard of care, and also gave the basis for reduction in the treatment time, which was tested in the Canadian as well as the Start B trial. So here again, the START-B trial was done only in node-negative patients, and no patient received boost in the Canadian in the Canadian trial. Whereas in START-B patients, predominantly 92% women were breast conservation, and again, the proportion of patients that were node-negative were 74%, and boost was given in small proportion of patients in the START-B, but no patient received boost in the Canadian trial. So the 10-year local 10-year risk of recurrence was comparable in the two arms, that is 50 gray and the 40 gray. However, with respect to the late effects, all the data favored the fractionation arm. Similar result was also seen with the Ontario trial, and hence it was very convincing to see the non-inferiority of the trials hypofractionation, both for the primary endpoint, that is the disease control, as well as late effects. However, there were several concerns with hypofractionation because initially, based on the trial population, the guidelines also recommended hypofractionation only for women who are more than 50, and also patients who had undergone BCS and those who are node negative and not receiving chemotherapy. And Choosing Wisely campaign was also initiated by ASTRO, and they then said they also published that HFRT is safe for post-mastectomy women. Whether it is safe for post-mastectomy women is not known, and those women with adverse biology, and whether only patients with pure DCIs also would it be safe to offer HFRT in such patients, and those requiring regional nodal irradiation, or those women with large breast size and in which you anticipate a higher lung and the heart toxicity. So the meta-analysis of the START pilot A and B trials was published, and here again they showed the non-inferiority or of most of the in most of the subgroups of wherever there was concern regarding the subgroups. So it showed similar result in the subgroup. Of course, this was not a pre-planned subgroup analysis, but the meta-analysis also showed safety of hypofractionation in most of the subgroups. This is also with respect to the moderate or marked physician assessed normal tissue effects comparing the conventional fractionation. So when you talk about the damaging effect on the heart, if you see if you derive the BED of the two fractionations, you can see that by presuming alpha beta for heart of around 1.5 gray, it is 48 gray, 2 gray equivalent. And if you presume an alpha beta of 3 gray, it is still 45.5 gray. So whatever presumption you make for the alpha beta ratio, it is still milder when you calculate the 2 gray equivalent. Hence, no excess of cardiac damage has been suggested from the trials, and also based on the radiobiological calculations. So the challenge is to protect the heart should be regardless of radiotherapy regimen by adopting breath hold or other heart sparing techniques. And similar finding has also been reported for large breasted women, and because even if you calculate the dose inhomogeneity between the two arms, it is still the 105 is still equal in the 2 gray 50 gray when you compare 50 gray with the 40 gray in 15 fractions. So it is a myth that dose homogeneity in the breast poses a risk to the patients by prescribing hypofractionation, and it is important to restrict the overdose volume in the heart. And in patients receiving moderate hypofractionation, at least there should be a concern of offering hypofractionation in large breasted women. The another trial that tested the weekly fractionation. 5 fractions were given every week, and the treatment completed over 5 weeks. And here again, though the eligibility criteria were quite broad, including patients who would up to 3 centimeter, or patients having negative axillary nodal status. But when the actual trial characteristics were seen, it was seen that 64% of women were more than 60 years, 72% women had undergone SNB or sampling, and 80% tumors were less than equal to 2 centimeter. And I mean, they were low grade and medium to small to medium size breast, and 90% patients were hormone positive. So this was the trial design in which they compared 50 gray with 2 test arms. One is the 30 gray in 5 fractions, and the other is 28.5 gray in 5 fractions. Both were given once a week, and the primary endpoint was 2-year change in the photographic breast appearance, and several other secondary endpoints. It was very important that to note that stringent quality assurance was ensured in all the participating centers, and a standard bitangent technique was used, and 3D compensation methods were used to improve dose homogeneity by employing breast compensators or forward plan IMRT, field in field IMRT, and inverse plan IMRT was restricted to very, very few patients. Only 1% of women had inverse plan IMRT. The volumes that received more than 50% of the prescribed dose were used to represent the whole breast PTV, and 95% of their RT charts showed that Dmax was less than or equal to 107%, and only 11% of the plants had more than 5% of the volume receiving 105% of the prescribed dose. So the point is that all the ultra hypofractionated regimens have to have an extremely good quality assured radiotherapy, and dose inhomogeneity has to be confirmed as per the recommended as recommended by the trial protocols. So if you see the comparison of the primary endpoint, which was photographic appearance, and by 5 years, you can see that the difference between the 30 gray and 50 gray was 7.4%, whereas the difference between 28.5 gray and 50 gray was only 2.4%, and this was not statistically significant. And the incidence of marked change was 2% versus 4% in the 30 gray arm versus 2%. So the 28.5 gray arm showed to be almost equal to the 50 gray arm. And they derived alpha beta of 2.4 gray for the photographic change, and a range from 1.3 to 3.5 for the clinical assessment. And if you see the 2 gray equivalent, you can also see that 28.5 gray is nearly equal, I mean 52.5 gray, but 13.5 is a little hotter. Hence, this was manifested in the form of increased toxicity. Coming to the fast-forward trial, in which there were, again, the eligibility criteria were quite broad, but the actual patient characteristics were quite similar to the fast trial, and they were all patients with favorable biology, and 24% of the patients had received boost to a dose of 10 gray. So this is similar to the fast trial. This trial also tested 2 dose levels, 26 gray in 5 fractions and 27 gray in 5 fractions. However, the primary endpoint of this trial is ipsilateral breast tumor recurrence. And again, it is very important to emphasize the rigorous planning and the quality assurance that is involved in all the UK trials, and they give exact method of the planning pack, which is published, is also very important to refer when you are trying to actually plan patients according to the fast or the fast forward protocol. So essentially, a field-based PTV is given. It involves tangential planning itself, and for the field-based PTV planning, 5 millimeter from the it is cropped from the skin as well as from the lung and the chest wall interface, and also 5 millimeter from the posterior beam edge or the MLC if there are MLCs in the main beams. So coming to the results, so it was a very large randomized trial. 4,000 women were randomized in the 3 arms, and you can see that the local recurrence was similar in all the 3 arms, less than 2% in each arm. So extremely favorable trial population, and similar findings are seen for the other disease-related outcomes. And we have 5-year result, 71.5 months median follow-up. This trial was reported at the time of COVID, and hence this formed the basis of adopting the ultra hypofractionated regimens during COVID times in many of the centers. The EQD2 estimates for the 40 gray is 44.7, but in the 27 gray is equal to 43.1, and 26 gray is equal to 40.6. So one would I mean, imagine why a lower dose has been accepted, why 2 dose levels were tested in this study. And so this was because in order to compensate for the time factor, hence these 2 dose levels were tested, and this would form the basis for deriving the alpha beta ratios also for the late effects as well as local control. So if you see, the green one is the p-values in green is comparing 27, showing the p-values of 27 in 5 compared to 40 gray, and those in the blue is comparing the 26 in 5 with the 14, 15. So as you can see, most of the endpoints, the 26 in 5 is having the difference is not statistically significant, except for the breast edema, where you can see, but if you see the absolute values, it is 1.5% versus 2.4%. Overall, if you see, the overall incidence of any adverse effect is also very less, 10.6% in the 14-15 arm and 12.2% in the 26 in 5 arm, and 15.9% in the 27 in 5 arm. So this trial concluded that 26 in 5 is the regimen that can be that is non-inferior with respect to local control as well as late effects when the treatment arm, when the standard arm is the start fractionation, that is 14-15. The other important trial is that addresses the issue of boost because all the previous trials did not offer boost, or if they offered sequentially. So the issue of concomitant boost is being tested in the import high trial, and this would also be very important in our patients because most of our patients are high risk and they need a tumor bed boost. So they dose escalated the SIB with intensity modulated radiotherapy after breast conservation, and they are testing the 2 dose levels of 3.2 gray and of 48 in 15 fractions versus 53 gray in 15 fractions, where the dose per fraction to the boost is 3.5 gray, and presuming that the alpha beta value is 3 gray. So this was also the initial results were also published in the SABCS in 2018, and you can see that the 53 gray arm, similar to what we observed in the fast forward, the 53 gray arm had increased in duration, which was reported at 3 years in 6% versus 7% versus 10%. And when you talk about the photographic outcomes, the photographic outcomes were not very significant in all the 3 arms. These were the trials that were addressing breast conservation surgery. Now, the remaining 2 trials of hypofractionation in mastectomy setting. So, the British Columbia trial, which was a smaller trial done in 300 patients, it randomized patients. The dose received was 37.5 day in 15 fractions, and this trial, this is not a trial addressing, RT versus one arm versus the other, but the indirect evidence we can receive from this trial, because here the fractionation regime was hypofractionated, and the standard arm was the no radiotherapy arm. So this has also shown no cases of brachial plexopathy at 15 years of follow-up, and no reports of grade 3 toxicity, despite the patients receiving RT to the chest wall, supraclav, axilla, as well as the internal mammary. And the primary endpoint also showed significant benefit from giving adjuvant radiotherapy in the mastectomy setting. The the Chinese trial has addressed the issue of proving the efficacy of hypofractionated radiotherapy with conventional fractionated radiotherapy. However, the dose per fraction that was chosen in this trial was a little higher, 2.9 instead of 2.6, which is the dose per fraction in the START B trial. And there was a logic in this, because in breast conservation, you generally give boost, but in mastectomy cases, generally a boost would not be given. Hence, a BED of 46 gray, which is the BED for 14-15, was considered a little unsafe, and hence this fractionation was tested in the Chinese trial. And here again, non-inferiority was chosen, and RT to the chest wall was given with electrons, and SCF and level 3 axilla was also treated. And no difference was reported either in the locoregional recurrence as well as in acute skin toxicity and late toxicities. So there is robust evidence for all breast conservation as well as hypofractionation, as well as for mastectomy. The other ongoing trials are the RTOG that is evaluating the 50 gray in 25 fractions with sequential boost with hypofractionated regimen, that is 42.7 in 16 fraction with sequential boost, and arm with concomitant boost, which is similar to the import high trial, that is 48 gray in 15 fractions. So we await results of this trial. And very important Indian study, that is trial that is ongoing, is from TMC Kolkata, and it is a multi-center study. Various centers in India are participating, and this is the HYPOT trial. And what is being tested is similar to fast forward, because our trial population is high risk, and we would be giving radiation to the breast, chest wall, and the supraclav. So the trial design is different from the fast forward. The fast forward trial has just a small lymphatic sub-study, which we await the results. But this is an Indian trial which would address Indian issues, and the approval is ongoing, and it will be a very important study to look forward. So to conclude about hypofractionation, so there are multiple debates. Is fast forward the new standard of care? One has to keep in mind the difference in what was included in the trial, because tumor bed boost was given in only 25% of the trial population, and synchronous boost are avoided because the investigators wanted to test the pure assessment of the whole breast fractionation without having to consider partial volume effects of different breast dose levels. And the HYPOT trial would give us the answer to this issue. And temporal trends in the normal tissue effects are expected to be different with non-uniform prescription of boost and synchronous administration. So the high-risk subgroups are underrepresented, and this is exactly the kind of population which the HYPOT trial is accruing. And hence, 5 fraction may be relevant to partial breast, or and the safety in regional nodal irradiation also It could be given, but we should await results of the lymphatic sub-study to make it as a routine treatment, as well as mature 10-year data is also awaited from the fast-forward trial. So should I go ahead with the APPI? This is the last part of my
Yeah, I think you can go ahead. I think it will take 5 minutes more.
5-10 minutes. 10 minutes more.
Yeah, you can come out.
Thank you. So coming to the last part of the lecture today, which is where I would be discussing the trials on accelerated partial breast irradiation. So what is APBI? It is accelerating the treatment where the target volume is tumor bed alone with some margins, and acceleration from, and it may range from 1 day to 1 week, compared to the whole breast irradiation where the treatment goes on for 5 weeks or 3 weeks. And the rationale behind this is that women who generally, especially in our setup, the patients who don't have access to radiotherapy may opt for mastectomy, or even if they opt for breast conservation, there is also a possibility that the patient may not receive adjuvant radiotherapy, and around 15 to 30% dropout cases have been reported even in the West. And so this offers an opportunity for breast conservation, which is the most important thing in APBI is optimal patient selection. And this is the chart that is showing various series when APBI was initially started. People were not very confident about which patients should be offered, and tumor characteristics that were unfavorable in the form of being lobular cancers or having positive margins or very large implant volumes. These were the inclusion criteria in various studies wherein very high breast recurrence rates were reported. And this highlighted the need of stringent case selection for APBI. So ASTRO gave the guidelines, and this categorizes them into suitable, cautionary, and unsuitable. And there are multiple factors that fall into the suitable category. Is very stringent, and it restricts tumors less than or equal to 2 centimeter and minimum 2 millimeter margin, no LVSI, and no EIC, and it does not allow DCIS also. And ER status has to be positive. Whereas in the cautionary group, these factors are little less restrictive, and focal or limited LVSI may even be considered. And the updated guidelines in 2016, they just dropped the age to 50 years. So the suitable category, which was 60, was made 50, and patients who were age 40 to 49 and who met all the other elements of suitability were considered cautionary. And patients less than 40 or those with 40 to 49 years who were meeting other elements of suitable were retained in the unsuitable group. So the guidelines have been revised from time to time. And similarly, we have the JECISTO guidelines, which categorizes them into risk groups, that is low risk, intermediate risk, and high risk groups. So important is that it does not take into account ER/PR status, which is different from the ASTRO guidelines. Whereas LVSI, it takes LVSI as the high risk factor. And in ASTRO, LVSI limited was allowed in cautionary, but extensive was not allowed, was considered unsuitable. So the main difference is the ER/PR status is disregarded in the ASTRO guidelines. So there are a range of techniques that can be employed for APBI. These include brachytherapy and non-brachytherapy techniques, intraoperative as well, and external beam radiotherapy techniques. So this is a busy slide, but it summarizes all the randomized trials. The one in the green block are the trials on brachytherapy, where the important ones are the POLGAR and the JECISTO trial. The ones in the blue are the EBRT trials, where various trials have employed either 3D CRT or IMRT to deliver APBI, or multiple techniques were used in the NACBP trial. whereas the ones in the red are the intraoperative radiotherapy trials. So coming to these one by one, the interstitial brachytherapy method is the oldest and having the most mature data. And this Budapest trial, randomized trial from Budapest, which reported the outcome, primary endpoint was local recurrence at 10 years and found no difference in the local recurrence rate. And when comparison of cosmetic outcome using the Harvard scale also showed similar results. This is the most important interstitial brachytherapy trial, which is from the Jekistro, and here 1100 patients were randomized between conventional whole breast radiotherapy plus boost versus APBI, which was given exclusively using multi-catheter interstitial brachytherapy. And the inclusion criteria were women more than or equal to 40 years and tumors up to 3 centimeter, patients who are node negative and with at least 2 millimeter margins and no LVSI. This trial was reported in Lancet in 2015 and 17, and it did not show any significant difference in the local recurrence rate as well as in the cumulative, in fact, the cumulative incidence of late side effects that were grade 2 or more was lower in the APBI arm, and that was expected. You can again note the extremely favorable trial population. Here, the recurrence rates are less than 2%, and the incidence of late grade 2 or 3 skin toxicity is also less than 5% in both the arms, and the incidence of late grade 2 or 3 subcutaneous toxicity was also non-significant. Coming to the balloon-based brachytherapy method, which is very popular, and the applicator is called Mammocyte. And though it has the relative advantages of having easier in application, it requires less expertise as it is implanted by the surgeon himself, and results in good to excellent cosmesis according to the registry trial. And near symmetric geometrical distribution is achieved. However, it has several disadvantages because, as you can see, the lumpectomy cavity may not be always regular, and hence there could be poor balloon conformance. There is a chance of balloon rupture, and very important, that is forms a part of quality assurance, is the inadequate skin spacing that can result in small-breasted women or tumors located in the upper inner quadrant because of requirement of to maintain an adequate skin to cavity distance. And interposition of air or fluids can also result in inhomogeneity, and the balloons are not available in different sizes, and hence they may not be suitable for all cavities or irregular cavities. And the dose fall off is very sharp in a balloon away from 1 centimeter away from the balloon. It results in a single large hotspot at the surface of the balloon applicator, unlike the brachytherapy, interstitial brachytherapy, and hence there is also a risk of infection, and increased late complications are also reported, specifically telangiectasia, because if the distance from the skin is not maintained adequately, the skin gets a very high dose, and this ultimately can have an adverse impact on cosmesis. And there were also publications wherein high mastectomy rate was reported in the brachytherapy cohort, and here brachytherapy was solely with the mastectomy. So we don't know whether these were recurrences or mastectomy was done because of managing radiation side effects in the form of radiation ulcers or telangiectasia. So, and the risk of mastectomy was higher in the brachytherapy arm. It was nearly twice. So this was quite alarming. Coming to the intraoperative radiotherapy methods, it refers to the delivery of a single fractional dose of irradiation directly to the tumor bed during surgery. And the tissues, the rationale is that immediately after resection, the tissue is rich in blood supply with aerobic metabolism, and hence it will be sensitive to the action of radiation. And it involves no risk of geographical miss, because the applicator is directly in the vicinity of the surgical specimen, resection cavity, and hence it can decrease the healthcare cost because radiation is delivered in single fraction. However, it has the disadvantages of not being able to have access to the final pathology, which would come only after surgery. Extra shielding is required in the theater, and it is also resource intensive, and it is an expensive technology. And very important is the inadequate coverage of the tumor bed because of limited penetration. So it is either available in the form of an electron-based machine, which is the Mobitron, or an X-ray based, low energy X-ray based machine, which is the target machine. So this is the slide that shows the dosimetry of the intraoperative applicator, and the treatment time ranges from 20 to 40 minutes. The pyramid-shaped lumpectomy is made spherical by wrapping the breast tissue around the applicator, and the movement of the X-ray source by even by a millimeter or the angle or the bevel angle in the ileot can change the dosimetry significantly. So, this is the graph that is showing the percentage depth dose across 10 centimeters, and you can see how strikingly the depth of radiation dose is very restrictive in both the mammocyte as well as intraoperative techniques. So this is 1 gray, this is 20 gray at 1 millimeter, and if you see at 2.7 millimeter, it is just 1 gray. So this is what has been manifested in the clinical outcome, and the result of the target trial that randomized again 3,500 patients and into whole breast radiotherapy versus target, and they at only a median follow-up of 2.5 years, the recurrence rates were pretty high. It was 3.3% versus 1.3% in the EBRT arm. And so early on, the recurrence rates were seen early on in this in this trial. Similarly, Eotc Trial also showed increased recurrences in the APBI arm, and this failure is essentially related to the dosimetry of the intraoperative technique. This was again a trial done in 300 patients, and median follow-up of 5.8 years. In the event rate was 4.4% and 0.4%, with a hazard ratio of 9.3. So intraoperative techniques trials were negative trials, and they suggest that intraoperative radiotherapy is not an optimal technique. Coming to the external beam techniques, that is the 3D conformal radiotherapy. This is the trial which had employed 3D conformal radiotherapy, and here twice daily fractionation was followed, and 38.5 gray was delivered in 10 fractions twice a day. So this again reported very high incidence of late toxicity as well as adverse cosmetic outcome. You can see the graph over here. The orange represents the fair poor cosmesis. So the cosmesis was almost, the poor incidence of poor and fair cosmesis was almost 15% versus 31%, almost doubles at 7 years. And this difference increases as the follow-up matures. The fat necrosis was also significantly more after APBI. Hence, it is 3D CRT, which was delivered in this schedule, that was BID schedule, and the dose fractionation was not in favor of was inferior compared to the whole breast irradiation. However, this was not noticed in the trial by Levy et al., in which the technique used was intensity modulated radiotherapy, and the overdose pill in the breast was controlled in a much better way. And here the BID fractionation was also not used, and the dose fractionation was dose was 30 gray in 5 non-consecutive fractions. So this has something to do with the BID fractionation as well as the total dose. And here this trial showed better results with respect to acute toxicity, as well as the cosmetic outcome was also better in APBI. The NACBP trial was also recently published, and this trial randomized patients into whole breast radiotherapy 50 gray in 25 fractions for to the whole breast and the boost was optional. And partial breast irradiation was given with a number of techniques, all the techniques of brachytherapy, balloon brachytherapy, as well as external beam radiotherapy, both 3D CRT essentially with 3D CRT were allowed, and the primary endpoint was ipsilateral breast tumor recurrence. And with 50% increase in the Hedges ratio was chosen as the acceptable margin for the sample size calculation. What you can see is that the absolute difference in the recurrence-free survival and the cumulative incidence of breast recurrence was very less, though it was very less. So the trial population was also extremely favorable. So there was no difference in the grade 3 or any grade 3 or higher toxicity or for second cancers in the 2 arms. However, it was a negative trial because the non-inferiority margin with respect to the non-inferiority margin, and the dissection of which technique is better was also not elucidated from the trial. This is the slide that is showing the ongoing studies. The Ironman trial has been published in abstract form in ISRO 2020, and the preliminary results show similar acute and late toxicity compared to the whole breast radiotherapy, and the technique that has been used is again 38.5 day in 5 fractions twice a day. It is similar to the trial that I discussed earlier. So we await the results of this trial in near future, and the another trial which is addressing APBI using IORT is the Cosmopolitan trial, and these are the ongoing studies, and we await further results from these trials. So to conclude, the success of APBI is dependent on the selection of right case, right technique, as well as right dose and fractionation. And the randomized data support APBI in select women in centers that have the expertise for a particular technique. And interstitial brachytherapy forms the most mature data. IMRT appears to be better than 3D CRT, and there is definitely a word of caution for the intraoperative techniques. And adherence to the contouring guidelines and dosimetric constraints is very important, and equally important is the quality assurance and prospective audits of our own cases. Thank you.
Thank you, ma'am, for such an awesome lecture and for clearing our doubts regarding role of radiotherapy in various possible scenarios. That will be extremely helpful in exam of our PG residents, both in theory as well as viva. We have some questions also. Mr. Sahil Gupta has asked that, ma'am, please tell me how much dose you prescribe in TMH for radiation for breast patient in TMH.
I mean, we follow hypofractionated, moderately hypofractionated radiotherapy, the START-B trial for all the patients 14, 15. But we have, we do offer fast protocol for patients who are node negative, who are early tumors, based on the 10-year data which was published recently from the FAST trial. And during the pandemic, we had approved patients with fast forward. All patients were being treated with fast and fast forward technique only. But now we have, moved away, and the pre-COVID standards are being followed in patients.
Okay, ma'am. Thank you. Ma'am, there is one more question asked by Dr. Vaishak, that isn't even a single node positivity considered an indication for PMRT?
So there is also scope for individualizing the treatment. I would not say that all node positive. It's not an all or none rule. The patients who have favorable risk factors, like if there is only one node but the patient is having no LVI, strong hormone positive.
Yes, ma'am.
Tumor size is also very small, less than 2 centimeter or so, and patient is elderly. Moreover, patient is having left-sided tumors and having comorbidities. So there are many things. One node positive, I presume, I consider that the patients have to be individualized case to case.
Based on the other risk factors.
Yeah, there is definitely a risk, the case for observing, especially for elderly patients, where you do not expect the risk-benefit ratio to be in favor of offering radiotherapy.
Yes, ma'am. Ma'am, Dr. Vaishak has asked one more question, that given all the uncertainty, when do you practice prophylactic Ironman irradiation in TMH?
We do not actually, we are not strong believers of prophylactic IMNRT, unfortunately, and we do not offer a prophylactic IMNRT in any patient. And as I have shown you, all the results have shown lack of benefit. So the meta-analysis which I showed was showing in high-risk population, and these are exactly the study. This is exactly the patients whom in which most of the trials have not accrued in a large number. Most of the trial population is 1 to 3 or high-risk node negative. So that's why we do not have a strong evidence for offering prophylactic interinflammatory nodal iron. But if you still want to consider, I think that 4 and more node positive would be the case where, and especially medial central, where you can offer radiotherapy.
Yes, ma'am. Ma'am, there is one more question. In fast forward trial, out of the 3 arms, 2 were 26 gray versus 27 gray. And what was the rationale in comparing such closed dose prescriptions?
I covered it in my lecture. So there were 2 reasons. First of all, they wanted to check they wanted to derive different study alpha beta ratios. So that's why they chose a dose level that was slightly with very small difference, so that they can achieve a difference in the alpha beta ratios while looking at the toxicity. And this was exactly seen in the trial, because the 27 gray arm was having higher toxicity, and when you compare the BD, it was hotter as compared to the 26 gray in 5 fractions arm. So that for radiobiological modeling, such closely dose leveled arms were chosen.
Yes, ma'am. And ma'am, Dr. Vaishak has also asked that what is your experience with ultra hypofractionation in TMH?
Experience, you mean to say we haven't analyzed the disease related outcome, but it is whatever cases we have treated, we have started the registry. They are being studied under we are capturing the late effects and all. But planning wise, I would say we have we are pretty confident now that we can easily deliver. I mean, there are no concerns, dosimetric concerns, that how to deliver and what those constraints to follow and all. And we are giving we gave a simultaneous integrated boost in all the patients. So dosimetric wise, we are very confident. We are very happy with the results. And coming to the late effect, the late acute toxicity, we haven't seen an exaggerated acute toxicity. So that anxiety is also no longer there. And talking about the late toxicity, we haven't, analyzed it, but the breast conservation cohort is being studied prospectively. It is the thesis of one of my, one student has already completed thesis. It will be passed on to the other, because we want to capture long-term data. But there is definitely some impact on, cosmetic outcomes. So this till now we are collating data. and the follow-up is not yet mature. I mean, at least 2 years we need to derive some meaningful conclusions. But preliminary impression is that definitely there is some impact on the cosmetic outcome. So we need to study this with respect to the other factors like the boost volume, the breast size, and other factors, patient and treatment related factors.
Yes, ma'am. Ma'am, one more question is there. Is node positivity a contraindication for APBI? And if not, will the axilla be separately addressed with EBRT?
Yeah, so this scenario is common when we generally we do frozen section for all the patients who are planned for brachytherapy, and in final pathology you come to know that the node is positive. So here again, if the node is micrometastatic, we do not alter the management, because micrometastasis we do not treat them any differently from node negative. So for node, but if it is a macrometastasis, and then we change the HPR by the third fraction, and so that we get the complete pathology, and we convert that radiation into boost the 3 fractions, and then we follow them up with whole breast radiotherapy with SCF.
Yes, ma'am. Ma'am, Dr. Haranim has asked one question that what are the indications for axillary node irradiation?
So inadequately addressed axilla, in patients who have undergone adequate axillary resection, we do not irradiate the axilla, even if the patient is having multiple nodes or soft tissues or all, because we are very confident that our surgeons remove the whole axilla. If the patient has undergone axillary resection at our institute, they thoroughly palpate the axilla, they remove the entire fat and the soft tissue. So we are pretty confident that nothing is left behind in the axilla. So that's why we do not give axillary radiotherapy. The only case where we give axillary radiotherapy is R+ resection, where the surgeon has left behind because the disease was stuck to the nodes or to the nerves. So that is the case where axillary radiotherapy is given.
Ma'am, one question I want to ask that if there is a difference in outcome with hypofractionated radiotherapy in relation to tumor biology, means like if the tumor is ERPR positive or negative, does it affect the outcome?
Oh, see, with the moderately hypofractionated radiotherapy, we are pretty convinced. I mean, we have the one of our students had done the dissertation also, and it's there in the as an abstract published in ESTRO already, and I think the manuscript would be published soon. So the moderately hypofractionated radiotherapy has not shown any inferiority with respect to conventional. Either with respect to the molecular markers or age or any of the whether it is a mastectomy or a breast conservation. So moderately hypofractionated, definitely there we haven't seen any adverse outcome. But for fast and fast forward, only mature follow-up will tell us more about the outcome.
Okay, so I think we should stop this because we are always running late. So thank you so much, Dr. Tabassum, for such a nice elaboration. And you compiled all the trials so nicely and concluded all trials so honestly. So thank you so much on behalf of Up-Aroi chapter. Dr. Shalin sir, would you like to say something or conclude something?
Nothing really. Thank you very much. Wonderful.
Thank you, Dr. Subodhi, for nice moderation. Thank you, Dr. Rashi. Thank you, Dr. Ashutosh. Thank you all the participants. Dr. Tabassum, thank you once again. Thanks a lot.
Yeah, if the students have any questions, you can email me. I mean, I can answer them on email.
Dr. Rashi, want to say something?
No, ma'am. Thank you only. Dr. Tabassum, she did a great job and at a very short notice. Thank you so much.
Thank you so much.
Thank you. Thank you.
Good night.